Hi, my name is Pamela Coons, Associate Professor of Medicine in the Division of Oncology at Yale School of Medicine and Yale Cancer Center. I'm excited to announce ASCO's new open access journal, JCO Oncology Advances. As the inaugural editor-in-chief, I hope to support JCO Oncology Advances to become the premier platform to bridge the gap between accessible scientific research and clinical care. Stay tuned for more information, including new article types, at ascopubs.org/JCO Oncology Advances. We look forward to seeing your submissions in spring of 2024.
This JCO podcast provides observations and commentaries on the JCO article Facts, an open-label randomized phase 3 study of Fulvestrant and Anastrozole in combination compared with Anastrozole alone as first-line therapy for receptor-positive postmenopausal breast cancer patients by Jonas Berg et al. My name is Matthew Ellis, and I'm a professor in the Department of Medicine, Division of Oncology, and leader of the breast cancer program at the Siteman Cancer Center in Washington University in St. Louis, Missouri, USA. My oncologic specialty is breast cancer medical oncology. Fulvestrant and Anastrozole in combination, fact or fiction. Fulvestrant and aromatase inhibitors inactivate ER signaling in breast cancer through several different mechanisms. Fulvestrant binds to ER and destabilizes the protein, causing a decrease in ER expression. In contrast, aromatase inhibitors dramatically reduce estradiol levels. Theoretically, these two mechanisms could be synergistic because the decrease in estradiol levels with AI therapy should increase the ability of fulvestrant to bind to ER and thereby potentiate ER inactivation and downregulation, increasing anti-tumor effects. This concept is supported by preclinical data whereby fulvestrant in combination with estrogen deprivation was more effective than either treatment alone in an MCF7-based model of aromatase-dependent ER-positive breast cancer xenograft growth. In these experiments, the combination of AI plus fulvestrant was associated with lower ER levels than either treatment alone, and both anastrozole and letrozole added significant benefit to fulvestrant in tumor growth delay. In addition to ER, greater downregulation of IGF-1R and downstream MAPK and PI3 kinase pathways were also observed compared to single-agent therapy. Osborne et al. Also found fulvestrant was more effective in the absence of estrogen through oophorectomy for MCF7 xenograft tumor growth inhibition. As a result of these promising preclinical data, 3 clinical trials were launched to test this combination approach in postmenopausal women with metastatic breast cancer, FACT, SOPHIA, and SWOG 0226. The FACT trial reported in this issue of Journal of Clinical Oncology is an open-label randomized phase 3 multinational study of fulvestrant in combination with anastrozole versus anastrozole alone at first relapse in hormone receptor-positive breast cancer. Patients were randomized to receive either anastrozole 1 mg PO daily or anastrozole 1 mg PO daily in combination with fulvestrant 250 mg IM every 28 days following a loading dose of 500 mg on day 1, 250 mg on day 14, and 250 mg on day 28 during the first cycle. 514 patients were randomized between January 2004 and March 2008. There was no difference in time to progression, TTP, 10.8 months on combination versus 10.2 months on anastrozole, hazard ratio 0.99, p equals 0.91. Clinical benefit rate 55% in both arm, or overall survival 37.8 months versus 38.2 months. A slight increase in the incidence of hot flushes was found in the combination arm, 24.6% versus the anastrozole arm, 13.8%, p equals less than 0.01. The results of the SOPHIA trial, study of fulvestrant versus exemestane versus fulvestrant and anastrozole in combination, is still pending. Despite the negative results of the FACT trial, enthusiasm for the combination of fulvestrant and AI was renewed after the recent report of the SWOG SO226 trial at the 2011 San Antonio Breast Cancer Symposium. SWOG SO226 trial is a phase 3 randomized study of anastrozole versus anastrozole and fulvestrant as first-line therapy for postmenopausal women with metastatic breast cancer. The inclusion criteria of SWOG O226 was similar to that of the FACT trial. Fulvestrant was also administered at the same dosing and schedule. The primary endpoint was progression-free survival, brackets PFS. The trial was designed to have a 90% power to detect an increase in median PFS from 10 months, anastrozole monotherapy, to 13 months, brackets combination, with a two-sided alpha of 0.05. In the intent-to-treat analysis of eligible patients, 707 patients were randomized in the period between June 2004 and June 2009. 694 patients were analyzed, excluding 12 ineligible and 1 who withdrew consent. The median PFS was 15 months, 95% confidence interval 13.2 to 18.4 months in the combination arm, compared to 13.5 months, 95% confidence interval 12.1 to 15.1 months. In the anastrozole arm, P equals 0.007, hazard ratio 0.8, confidence interval 0.68 to 0.94, favoring the combination therapy. This was accompanied by a statistically significant improvement in overall survival, combination therapy 47.7 months versus anastrozole arm 41 months. P equals 0.49, hazard ratio 0.81, confidence interval 0.65 to 1. Interestingly, in the subset analysis, the improvement in PFS 17 versus 12.6 months, P equals 0.0055, and overall survival 47.7 months versus 39.7 months, hazard ratio 0.74, P equals 0.036, was found only in patients who had no prior adjuvant tamoxifen therapy. N equals 414. AEs did not differ significant by treatment group. Grade 3 toxicities were 13% in the combination arm and 11% in the anastrozole arm, including musculoskeletal pain, fatigue, hot flashes, mood alterations, and gastrointestinal symptoms with a frequency of 1 to 4%. The positive finding of SO226 stands in contrast with the negative result of the FACT trial. However, there were more endocrine-naive patients in SO226 than in the FACT trial. Compared to the FACT trial, in which 30.2% in the combination arm and 35.2% in the anastrozole arm had no prior endocrine therapy, 38.9% of patients in SO226 had de novo metastatic disease and were thus were endocrine naive. This is consistent with the observation in SO226 trial that the benefit of the combination was restricted mainly to those who had not received any prior tamoxifen. In both trials, the number of patients who had prior adjuvant AI was minimal. These data suggest that the combination approach likely works best as first-line therapy, such as the adjuvant and neoadjuvant treatment settings. A weakness of both trials is they were conducted with a lower dose of fulvestrant at 250 milligrams monthly, which is now known to be inferior to the approved 500 milligram high dose in both the first and second line settings. Thus, it is not clear that the proposed synergy between anastrozole and fulvestrant seen in SO226 is due to anastrozole compensating for inadequate fulvestrant dosing in some patients or a true positive interaction. Furthermore, neither trial had the third arm of fulvestrant alone necessary for full evaluation of the synergy hypothesis. To determine what these findings mean for the adjuvant therapy of breast cancer, the Alliance for Clinical Trials in Oncology will activate a neoadjuvant endocrine therapy trial, alternate approaches for clinical stage 2 and 3 estrogen receptor positive breast cancer neoadjuvant treatment, the alternate study. That will compare fulvestrant at 500 milligrams monthly with a 2-week loading dose with anastrozole and with the combination for 24 weeks of neoadjuvant endocrine therapy. The protocol is designed to develop a superiority hypothesis based on the preoperative endocrine prognostic index, or PEPI, to be taken into the adjuvant setting. In the meantime, the combination of anastrozole and low-dose fulvestrant should not be considered a standard of care, and these agents should be continued to be used at their FDA-approved doses as sequential monotherapy. This concludes this JCO podcast. Thank you for listening.
For more original research, editorials, and review articles, please visit us online at jco.org. This production is copyrighted to the American Society of Clinical Oncology. Thank you for listening.